Hey, deserving listeners. I have a special guest with me today, Lisa Rudduck. She is going to talk about chemical dependency and also the substance abuse treatment concentration at Antioch. But before we get to that, I just want to start with a little preamble here and say that traditionally in the field, when I entered the field in the 90s, I really did get a sense that the substance abuse treatment field was something completely outside of psychotherapy. There were psychotherapists, marriage and family therapists, counselors, psychologists that were sort of loosely together, a lot of infighting within those groups anyway. And then chemical dependency people were just like this whole other thing. And almost they were looked down on as like, well, they're not real counselors. They don't know what they're doing. They're this isn't me, of course, but things I would hear is like, oh, chemical dependency people, they're just former addicts, leading the blind, or whatever it was that people would say. At the very least, it's just like a very big divide. And as I entered the field and started working with actual clients, I realized that a lot of people have addiction issues, substance use issues, in addition to the presenting problems they bring into therapy, and or they have family members who have issues with substances. And just by osmosis or experiencing it through that, I became, over years and years, sort of an expert in helping people from my vector of helping people as a marriage and family therapist to help people with substance use issues. And I took some continuing ed, and then when I was getting my doctorate, my main internship was actually at a chemical dependency treatment center, and I was one of the psychologists that was there. It was mainly chemical dependency people. And so I really got to know the business during that time. And I think we still need to really work on collaboration and whatnot. But part of the solution, I think, is to have more integration, right? And so Antioch is actually trying to do that. And so I wanted to have Lisa on the show today to talk about that, because she's really been spearheading that effort for the past number of years. Welcome to the show, Lisa.
Thanks, Kirk. Thanks for having me.
So just at the top of the show, do you want to plug like where people can find you just right away, just to get that out of the way, and we can do it at the end? Like where can people go on the internet to find you?
Actually, right now I'm kind of in transition, interestingly enough. For a really long time, I had a private practice in Kirkland, Washington. About 9 years I was in private practice, and then my husband and I moved to Austin, Texas for a year. We came back last fall, so and I've just started my PhD, so I'm still kind of setting up shop and figuring a few things out professionally. Yeah,
people go to Antioch, and you would be in the CMHC page.
Yes, exactly. Yes.
Lisa Rudduck. And you came to Antioch teaching what in the beginning?
It's so funny. A colleague of mine that was in the same office park where my private practice was approached to teach the addictions course, the survey of addictions course, which was just an intro survey class in 2010. And she jokingly in the parking lot one day was like, "Hey, Lisa, they asked me to teach this class, but you know me, I'm just like not organized enough to do it, and you're so type A, you're perfect for this." And so she passed it off to me, and I came in as an adjunct. And
so had you taught before?
No, it was my first time.
And you were a counselor?
Yeah, I have been in the field for a number of years. I started pretty young. I started in the field around 2002 as a chemical dependency professional. I worked at United Indians of All Tribes Foundation. And then I worked for a big treatment center in Seattle for a number of years until I decided to get my master's degree.
In counseling?
In counseling,
So to people that don't know,
sure.
CDP is Chemical Dependency Professional,
right,
which is a state designation.
Exactly.
It's like a license, essentially.
Exactly.
And in order to provide chemical dependency treatment, you have to be a chemical dependency professional,
yes,
or a trainee.
Yes.
And then you also have licensed counselors, which you are also as well.
Exactly.
Why did you want to become a licensed counselor?
Well, my career's been sort of an evolution. Like, I didn't really know what I wanted to be when I grew up kind of person. I sort of just kept learning, growing, and kind of came into, what was now my purpose. And I'm really glad that I have, found something I'm passionate about. But I think what happened for me was I was working in the addiction treatment field. And it wasn't too long into my career as a counselor, as a chemical dependency professional, that I realized I wanted to do more. And in order to do more, I needed a master's degree. And so I pursued a master's degree and got my licensed mental health counselor.
More meaning that you were treating people with substance issues and saw additional issues that they were suffering from that
Yes.
wasn't your jurisdiction.
Yeah, and I sort of moved up quickly. I was a kind of a go-getter, and so I was a counselor, and then I was a treatment director, and then I was asked to open up a family program, and I think that really brought it home for me, working with the family members, that if I was going to work with the family system, if I was going to work with significant others or couples, or just the ripple out of addiction is huge, generationally. The impact is huge.
Right.
And kids and, you need more education. You need to be able to do more. And if you're treating the family, it's interesting to treat the person with addiction in a treatment center. You get a chemical dependency professional and you can be a counselor. To treat the family, you need a licensed mental health that's where they go as therapists and counselors. So I guess on some intuitive level, I knew I have a lot of years ahead of me. I'm capable of more. I love school. I'm going back.
Apparently, you're also now getting your doctorate. So you started teaching as an adjunct, and then you started teaching more full-time.
Yes.
They hired you on full-time. I had the same path. I was an adjunct, and then I became full-time. And then there was talk with you and Colin about starting a chemical dependency concentration for people in the master's program. I suppose people in the PsyD program could take it as well, but it's mainly for the master's people. And it's a concentration in which you, in addition to becoming a licensed marriage and family therapist or a licensed mental health counselor, you can take these 4 classes that span a year. So it's 4 quarters, consecutive courses. And at the end of that time, you can what with that? What does that qualify?
Well, the story is kind of a cool story. It's like one of those when the stars align stories, because, Colin's a very passionate man, of course, and he had a lot of pots cooking on the stove at that time, and one of them happened to be, he was kind of like looking at how can we help specialized tracks for our students, so that if they want to start honing in on a specialty while they're in graduate school, how do we help them do that? And so, he thought, Lisa, addictions, I was teaching more, I'd been there a while. So he approached me about that, and simultaneously what was happening in our state is huge. Because the Department of Health was asked to form an advisory committee to look at how to make, this is their language, an alternative learning track for 7 different professions, the licensed mental health counselors and the licensed marriage and family therapists being 2 of them, to make it easier for them to become chemical dependency professionals. Because you see, traditionally what has been the case is, for me, getting a CDP and then going and getting a master's degree is just a natural progression. But if you think about it the opposite, you go get a master's degree and then you get licensed as an LMHC or an LMFT, it's very difficult to motivate people to go back to community college for the 45 credits they need and then get all this other experience stuff to get a CDP. And so the state of affairs in our state is that
meaning that you're already working, it feels like a step backward. There's also an internship portion, right?
Yeah, and that's never going to go away. You need work experience hours, the same as, with anything that you were trying to learn. But
was the state worried that there weren't enough CDPs around? Is that what they're?
There isn't.
Okay.
Yeah, there isn't. We really, especially in rural areas of Washington, our, Governor Inslee and press releases I've seen, and just, he is very pro integrated care. This move towards, or this, hey, come up with an alternative learning, come up with a way that's not, 45 credits of classes that these folks need to get in order to become a CDP. Because we need more out there in different settings. So it's interesting, the list of professions that are allowed to pursue this alternative learning track. It's nurses, I believe, physicians, LMFTs, LMHCs, licensed social workers,
Guessing psychologists.
Yeah, there's 7 of them. But basically, it's reflective of these professions that are coming into contact with addiction. And, in our state, in order to work in a facility and administer anything that would be deemed a treatment and addiction treatment service, you need to be a CDP.
Right. So traditionally, and there's more of a gray area, but to speak in a black and white term, if a person came in with what we call dual diagnosis, and they had anxiety or relationship problems, and they had substance abuse problems, that patient would have to go to 2 different professionals. They would have to go to someone to treat the psychotherapy side, and then they'd have to sometimes go to a completely other building or facility, completely separate organization for their substance use issues, which is fine on some level, but on another level, it's like, why not have either people integrated in the same office, CDPs alongside counselors and therapists, and or have one person that's capable of doing both.
Exactly. And it's interesting because it's also just reflective of, I think, the evolution of the field. I mean, I'm a huge history buff. I love thinking about history, learning about history. It provides so much more understanding for the way things are. And that's, history of families, history of our country. So, and the history of treatment, I teach quite a bit about in the survey course, because it helps students understand why we are where we're at.
Well, what is the history?
Well, so, once upon a time, and I mean, not unlike mental health issues, addicts and alcoholics were misdiagnosed. They didn't know what to do with it. I mean, they were thrown into sanitariums. They were, all kinds of strange things, in order to quote unquote treat, people with addiction. And, I think what over the course of the evolution of addiction treatment, what sort of my sense of it is that there's like this underlying mistrust in some ways with mental health, because they don't always get it. They don't always ask the right questions. They don't always, many of the people that I've had as clients that are in recovery will tell me they went to therapy for years and the counselor never asked them about their using. And that's kind of primarily what's causing, a lot of the unmanageability in their life, a lot of the relationship breakdown, a lot of their inability to go for their dreams, or, why they're depressed, if somebody's drinking every single day. So I think that there's been this, it's also influenced by, the evolution of abstinence-based treatment, AA, Alcoholics Anonymous, and there sort of being this way to deal with addiction that came into being. And so with that went this sort of, I think there's this protective energy. Like we know how to do this. We know how to help each other into recovery. You go to treatment, where you get stabilized. There's a saying that treatment's discovery, not recovery. It's a place to get stable. And then, the abstinence-based model is 12-step recovery world will take it from there. And, by and large, it is pretty effective. I mean, there millions and millions of people, go on to become, very sort of fulfilled in their life.
I have seen it work, that model, many times. And I totally understand, and because I've worked really closely with people with substance issues, I totally understand that it's a journey. It takes a long time. It's, there's going to be falling off the wagon occasionally, and maybe even for a couple years, but you get back on, and but people who go to meetings, they just keep going, like they say, just keep coming, and eventually you improve your life, and whatever that looks like. I find that when I hear on podcasts or in the news on the internet, and I'm guessing you have too, when people talk about AA and 12-step programs, they talk a lot of crap about it. It's like it only has like a 2% success rate or whatever the stat is. Yeah. And they're like, it's never worked. And if that's all we got, then the field of chemical dependency has completely failed. And, I've heard a lot of different things about that. And I'm curious what you think, but just a little snippet of what I think is that people outside of substance use treatment and maybe even just substance addiction themselves, they've never been through a massive addiction for themselves, them or someone close to them, and they just don't understand. They think of it as a medical treatment, like okay, I have a broken arm, and you put it in a cast, and the treatment has now worked. Yeah. Or you have a broken arm, and you give someone an aspirin, and that doesn't work. You know what I mean? Like they're evaluating the efficacy of the model that you're talking about from a sort of a medical model, and when it comes to life and decision and motivation and all the other things that come into addiction, like trauma and relationships and habits and stress and all those things, it's like it's really treating, when you're recovering or getting sober or improving your life, you're treating the whole human, spiritually, bodily, physically, psychologically, relationally, and it's not just like putting a cast on an arm. You can't evaluate it that way. What do you think about have you heard people say?
Oh, sure. And I mean, it's one of the things we go into a lot of discussion about in courses in the concentration. I think a few things. One, I think there's a lot of misunderstanding about role, function, what happens with 12-step. The founders of Alcoholics Anonymous, Bob Smith and Bill Wilson, they weren't making a scientific treatment. They were two alcoholics who experientially discovered that when they were talking with each other about alcoholism, they weren't drinking. Like, that's as basic as it is. And then they decided they needed some sort of bridge, some sort of process to help newcomers understand how to kind of change into, or some path for transformation into, how do I go from the darkness of addiction into the land of the living again? And so their experience was they took these steps, and that helped them clean up the wreckage from being, all unmanageable and crazy in addiction, especially in their relationships. So I think it's unfair to compare it or to talk about it in the context of scientific treatments and or medical treatments.
But that's the world we live in, right?
That is the world we live in.
Especially now.
Yeah. But the function of it's like, to go back to your broken bone analogy, I mean, when you break a bone, and depending on how bad the break, and so of course some people are further along in addiction than others, or have been active in addiction for longer. You put a cast on, which is essentially going to treatment. You're stabilizing the organ. Like, the nervous system is really unstable and it needs stabilization. And a lot of people aren't eating and drinking water and sleeping. I mean, so biorhythms are super off. They haven't had any kind of like normal routine or structure, and they literally don't have the impulse control to not use. So they go away and the bone gets set, right? But just because there's a cast on, I mean, there's a whole bunch of other healing that needs to go in after that. So, AA is one of many ways, or 12-step world is one of many ways. But I think bottom line is, in order to really heal or recover or transform your life from when you've been living in active addiction, there's got to be something, and it's usually a combination of things that helps that rehabilitation process. How do I go be in relationships when I've been isolated, shooting dope every single day in some, little den somewhere with two people and not even talking, because that's, that sometimes that's where people go. It's just a very isolated life. Just because they go to treatment doesn't mean they're going to know how to get out and function in the world or do stuff. So you and Colin started this concentration, and it is in response to the new these new guidelines set out by Washington State. That was kind of the synchronistic piece. Is I happened to be pretty tuned in to what was going on specifically in the CDP field. And so when Colin approached me, started having these initial conversations, I was like, wow, funny you should say this, because, the timing is pretty prime right now to do that at the graduate level. So I said, let's take our time a little bit and pay attention to what's happening. I went to the advisory committee meetings and just watched the process of them come up with this alternative learning track. And, it was very reflective of the history. There was people that were really protective of which rightly so, of, wait a minute, just because you have a licensed mental health counselor or an LMFT doesn't mean you know how to treat addiction. So you definitely need to still get some education and work experience hours. There was a lot of advocacy for that.
Meaning that there were people who were saying that mental health counselors should just be allowed to do CDP work without any extra training? Is that what you're saying?
I don't think that was ever an idea. I just, when you watch a group conscious kind of take place in an advisory committee meeting, of course there's going to be biases, or there's going to be certain people that are, have strong passions about things one way or the other. Oh. And there's a lot of, which I think is residual from the history. There's a lot of energy around, people didn't want to, it went from 45 credits to 15. Well, some people thought that was too few.
Yeah.
That there needed to be more. And then the topic areas is another area of debate. Like, what topic areas do you absolutely need to know? Then the work experience was another. And then how those hours are supervised and in what setting.
Yeah, I would actually argue personally that if I was on that advisory committee, I would have actually asked for more credits as well. Not to say that the people who get this education and certification are unfit, but it is a complicated area.
Yeah.
And anyway, so the state, let me just clarify what the service that you're providing at Antioch, which is you are offering not only to current students in the master's program, it's like, hey, while you're getting your master's, use some of your electives.
Yes.
You have to take electives anyway.
That's right.
And or take some extra classes, just a couple extra classes, and you will graduate with the ability to move on and become a CDP.
Yes.
And so they have to get actual experience working under a CDP, I'm guessing, right?
Yes, absolutely. Yes. That's one of the biggest, which I'm as somebody in the field that's my specialty, addiction and trauma and family affected by addiction. I was really impressed by the advisory committee. I have a lot of respect for the process I watched them go through. I think it was very fair. I think that a lot of it's hard to let go a little bit and change and kind of open up to something new. And I was really glad I got to watch that process happen. And,
given the history.
It's a move towards integrated care, and it's a move towards respecting each other and trying to work with one another.
Yeah. And I could see how CDPs would be pretty threatened by this, because it's like, wait a second, all the people who have been stomping on us since the beginning.
Yes.
With this, this is a little bit extra education. Suddenly now they can do they can start bossing us around even more. You know what I mean? I can imagine that being upsetting to a lot of people.
Yeah, and I think, again, it goes back to there's that underlying, there are a lot of people in recovery who are CDPs or working in treatment fields. So there is still a little bit of that underlying, you better know what you're doing. And I'm holding your feet to the fire, if as a clinician, that you know what you're doing and you're competent to work with addiction, which I think is a good thing. I mean, I think it's a protective energy.
Yeah, absolutely.
I think also, though, on the flip side, and this is kind of what I've learned and grown into as an LMHC and, just learning a lot more in the field over the course of my career, is that also, there are a lot of other issues that are accompanying addiction that need to get addressed. And so, ideally, where we're going is more integrated care. That means that, clinicians who are duly credentialed have the ability to track everything that's going on, acknowledge everything that's going on skillfully, which means you're not in over your head trying to bite off something that client's not ready to deal with yet. And that you also have the ability to help with the process of stabilization and keeping it simple early on, which is a lot of times what needs to happen. And in our concentration, we study a lot about the 12-step world because, and alternatives to that, because I want our counselors that, are finishing up in our program, I want them to be able to go out and speak all of those languages so that they can tune into whatever their client is working on and whatever is making sense to their client. And if it's 12-step world, they know what's the benefits of the 12-step world and how their client's jiving with that. Right. And they don't do anything to get them off track.
Right, because what's different, I'm guessing, about CDPs as opposed to counselors and therapists who also have a CDP add-on to their degree is that the vast majority of CDPs went through 12-step programs themselves.
I would say, it's hard to say the vast majority because I don't really know. There's certainly, I've
never met a CDP who hadn't gone through 12-step.
Well, I'm sure there's a fair amount that did go through a harm reduction, could have gone through a harm reduction.
They've been through treatment.
But they know it because a lot of treatment is abstinence-based and includes 12 steps. So
right. So that's the best education, right? You go through it yourself. Whereas,
pretty much, yeah.
I would imagine there's a fair amount of counselors and therapists who have no, in my experience as I'm teaching students, have no clue what 12-step world is or even harm reduction world.
Yeah.
And so I imagine that's a difference too. So just to really get specific, I'm mostly just curious for myself.
Yeah, sure.
As students ask me these questions is, so some of the interns will be able to get your CDPT hours at your internship before graduation, right?
Yeah, it's funny.
If you find the right location.
Absolutely.
And then right after graduation, you can qualify as a CDP, correct?
Well, it doesn't quite work like that. It's a little bit, I actually just recently made a flow chart because it gets a little bit confusing, but it's an important question to ask and one that I think might get hammered out a little bit more as time goes on. It's funny, there was a public hearing during the advisory committee meetings and it was the only thing, because I'm kind of a stickler for details, it was the only thing I commented on as a public observer, which was that I think that the associate status, the LMHC A's and the LMFT A's are going to get really confused about how to accrue hours towards both credentials. Okay. And I think that's something the Department of Health will probably be working with people to figure out. So it's very clear if you're already licensed.
Okay. So it's unclear if recent graduates, we in Washington State, they're called associate licensed people. It's unclear how they can get CDP.
It's not unclear how, it's just confusing. Oh. So if you think about it like this, and some listeners, we're just going to be kind of talking shop for a minute, but our students, they get done with their master's degree. And once they're done with their master's degree is the point at which they open a application with the state to start accruing their hours towards license.
Yeah, post-grad
With a CDP, you don't have to complete a degree. So you just have to have started your education credit. So technically speaking, our students in the concentration right now, for instance, are at internship sites, most of them, where they're starting to accrue their CDP hours because they've started their coursework at Antioch. They're going through the concentration. Right. Now, once they complete their degree, it's almost like they're going to put a pause button on that and start pursuing their license hours.
Oh,
because they want to get their license first, and then they finish up their CDP hours once they're licensed. So
that's typically.
And the question will be, and will kind of remain, can you if you're doing some chemical dependency type services while you're getting your hours towards licensure, could you also count those? Right. And that's the thing I think we're going to be working with the Department of Health to just sort of figure out along the way.
Okay. What if you get the, and I just want to say before I forget that you also offer to alums or anyone who's licensed post-grad people to come back.
Absolutely, yeah.
To come back to Antioch, take those 4 classes or however many they didn't get when they were in their master's program.
Yeah.
And become a CDP as well.
That's right, because I mean, basically, as it stands, right, those 7 professions that are listed in the alternative learning track, those are already licensed professions.
Right.
So all of those professions are going to be looking for 15 credits of coursework if they want to get a CDP. So ideally, we would want to be opening it up to all those professions as well. Eventually, we're working on a certificate program right now. Doing all the steps to make a sort of quote unquote certificate program, which makes it easier for alumni to access financial aid if they want to come back and do it.
Right. Because they're not matriculated fully. They're just for those courses.
That's right.
So I want to take a break, and when we get back, let's continue talking about it. Okay, we're back from the break. If you haven't become a patron of the podcast, do so now. Go to patreon.com, become a patron of the podcast. Okay, so when people, just to drill down on this a little bit further, again, because I'm just curious, is that people who are already licensed, like myself, let's just take me.
Yeah.
If I somehow got into this program and took these classes, and then during those classes or after taking those classes, I would also have to get official CDP training hours.
That's correct.
Of experience, but while being supervised by
that is correct.
A CDP. Okay. And so that's interesting. And then for the students, then at internship, depending on their internship, they could actually start accruing how many hours do they need?
I don't know, because
is it
I
like
rely so much when I
200 or
on
something?
my cheat sheets. It's more than that. I think it's around 1,500 is what I want to say.
But client hours, I guess. How many client hours?
Ooh, good question.
That's the main one. Anyway.
Yeah, it's a fair amount of that. Okay. Yeah, it'll take a while. Yeah, they'll need to be in a site, and there's approved, just like LMHC and LMFT, there's approved supervisor criteria.
Right.
And they need to sign off on that. And
so CDPs with experience, essentially, right?
Exactly.
Yeah. And so the only way they could get their CDP right after graduation is if they had a job under a CDP. Would that work?
Well, the reality is very similar to the LMHC A status. When they start doing even internship while they're in grad school, if they're at a site, for instance, that's a treatment center, I have a few students at treatment centers right now that are in the concentration. What you do is you open up a CDPT, a trainee application. And as soon as you've opened up that application, you're saying to the state, just like you are when you go get your LMFTA or your LMHCA, right? You're opening, saying, I'm in the process of accruing all of these requirements to get this.
Right.
So they can they have to do that in fact, if they go internship at a treatment site. Right. Whether they're going to do it or not, it's a requirement to be a CDPT trainee.
Yeah.
And once they're the trainee status, again, they can, if they're, all of their hours are being supervised by an approved supervisor at internship, and they're delivering and administering chemical dependency services, then they can start accruing those hours towards CDP. And then once they've graduated, this is where I think we'll be working with students, and they'll be working with the Department of Health to figure out, and basically the information I've gotten from the Department of Health is it's going to come down to the supervisor that is supervising the hours, right, will need to be in place in order for, and then also what the agency is billing the hour for. So if the agency was billing the hour for a chemical dependency service, that could count as an hour towards the CDP. If they're billing it for mental health, that will count as an hour. So students will have to sort of keep track of, if I'm working 40 hours a week and 10 of them are committed to doing CD groups at my site and the other 30 are being billed out as mental health, then I'm going to be putting 10 hours down, slowly getting my CDP hours, and 30 slowly getting my...
Seems logical to me.
That's kind of what's going to be happening for the duly credentialed folks. And I imagine there's going to be some hiccups. I mean, keep in mind, these rules just came into effect 2016.
Right.
So I don't even know. I mean, they're probably just getting their first batch of applicants, and institutions just like ours right now are still in the process of making these 15 credit concentrations or programs so folks can pursue, the alternative learning tracks. Very new.
What other universities in the area are offering this?
I believe Seattle University has a program. I don't 100% know the one. I don't know with 100% certainty ones that are actually up and running.
Okay.
Again,
but Antioch really got on the cutting edge.
We did, again, like the stars were aligned kind of thing, and it was really synchronistic, the timing of Colin and I starting to talk about that, and then me attending those meetings, the rules going into effect, and it just all kind of fell into place really well. So
what's the feedback from the students?
So far my first group is really liking it. It's interesting because obviously I've never created a program for an institution before. So it's been a real process, a real growth and learning process for me to create courses.
Yeah.
And I have such a deep sense of responsibility to the program and to the students to do such a quality program. And so
you're kind of like
put a lot into it.
You're kind of like a little chair in a certain way.
In a way, yeah. I mean, I created the thing, and I'm, when any new program is new, it's small. So it doesn't, you can't justify having more than one person on it. But I mean, so far so good. There's the survey class is the first class that you take, and that's actually a required class for CMHC students. And then there's 4 other classes. And, so far when I've looked at evaluations and feedback, the students are really liking it and getting a lot out of it. I think the ones that are pursuing the concentration as interesting are the ones that really get lit up in the survey class. And it's funny because I watch students sometimes come in and they're like, I don't want to touch addiction with a 10-foot pole. This is like so... And then, they start learning about it and realizing, oh, actually, I'm not going to be able to avoid it, A. Right. And B, when you start to understand it and start to explore it more, and even, one of the assignments in the survey class is to go to a 12-step meeting. I mean, that's probably one of the most awakening, transforming learning experiences for students. They have so many misconceptions and assumptions and bias, and they go and they come back and they're like, I wish I had a place like that to go. I mean, so it's just funny to watch, but I watch some of them, the passion light comes on with working with family, because we do spend a lot of time in the survey class looking at the family system as well, and towards the latter part of it, trauma, because these two things go hand in hand. And so I think that the people I watch students wake up to, this could be who I want to work with.
Wow. Yeah, it is weird how students will have this weird bias. Mm-hmm. Society must be giving the general public a lot of messages that make it feel distasteful or not preferred or something, because I hear that a lot too. And whenever I advise, and I've always advised students from the beginning, because in the MFT program, we call it the abuse elective series, where they can take domestic.
Oh, yes.
They
Okay.
can, They can take they choose between the domestic violence course or the addictions course. And I'm always telling people, look, they're both important. And if you have time, really take both of them. But if you really have to choose one, choose the addiction one, because the percentage of your clients who will be suffering, or someone close to them suffering from a substance issue, in my anecdotal experience, is much higher than those who are suffering from a domestic violence issue. Domestic violence and intimate partner violence is really quite common, and abuse is common. But the other thing is I think that without a class in addictions, you will be completely ignorant of what is happening. Yeah. Whereas with intimate partner violence, it's not. It'll get talked about in other courses, you know what I mean? And so I'm always saying, hey, if you're on the fence, I recommend you take the addictions course. I took the addictions course back in the day, back when Lisa Erickson was teaching.
Oh, sure, yeah.
You must have been replacing Lisa.
I think so.
And because she taught it for 20 some years or something, and she's been on this podcast actually talking about gifted children, but. I took it back in '96 with her and had a very similar experience. Just like, whoa, this is interesting. Every week it was light bulbs going off. And they had us go to 12-step meetings. I went to an Al-Anon meeting, if I remember right, and that experiential time in those groups, I'll never. I mean, this was 22 years ago, and I remember like events that happened in that Al-Anon meeting, and it is very eye-opening, and that's interesting to hear you say that, because I think I was one of those people. It's interesting. So in that class, people are like, I think I want more education in this. And
especially with trauma. I think that I've been really, really fortunate to have a lot of really great teachers. I'm a level 2 sensory motor psychotherapy graduate, and then level 1 internal family systems. And it's a very compassionate, they're both very compassionate, loving approaches to treating trauma, and also very scientific. So I think the combination of, for me, which I've then sort of been able to, I think, impart to students, is that to be able to expand your capacity for compassion around these conditions, and also simultaneously understand the science behind it. I think it really helps students at the end of the day almost kind of feel more confident around, I could do this. I think it kind of is a scary, overwhelming thing at first. It's like this, I don't understand it, and it's scary because I don't get it. What are they doing? And I don't even know what I would talk to somebody in the room who was struggling with, like, what would I even say? That's just, I don't even get it.
Well, and they've seen episodes of, what's that Dr. Drew?
Celebrity Rehab.
Yeah, where everyone's screaming at each other and there's super chaos and it's all played up for cameras and stuff like. Well, what did you think of that show?
That is inpatient treatment. I mean, it's
I have to admit, I've only seen like 5 minutes of that show. So
I think it's I don't understand what's going on.
Okay.
Or I'm focusing so much on you can really focus on it in a way in which it's sort of like, watching reality TV. You're like, oh my God, these human behaviors, like how crazy. But I think, again, if you watch that, and we do watch quite a few things together as a class, and I actually have used some Celebrity Rehab clips, because if you can watch it through a different lens, and you can watch it through a look at this nervous system attempting to regulate itself and desperately trying to grab onto something, and look at the relationship dynamics and how this is the only way they know how to relate. It's the only, they're living out of survival skills most of the time. A lot of, if you really just turn the volume down and watch the body language and it's a lot of living out of fight, flight, and freeze. And just blowing each other up and then nervous systems resorting to fight, flight, and freeze over and over again. So again,
And then they turn to the substance to calm their nervous system.
Or yelling at each other, or sleeping with each other, or stealing each other's stuff, or lighting something on fire. I mean, you name it. I mean, that's inpatient treatment. You ask anybody that's worked in residential treatment, and that's a daily, it's not just a TV show. I mean, it's any of the centers. There's a lot of interesting stuff that goes on a daily basis, because the nervous system, it's been relying on addiction as its main way to deal.
Right.
That's been taken away. Nothing's replaced it.
Yeah.
So.
And, you let me know if this makes sense. A common story, a common history for someone who ends up in treatment or ends up in my office talking about various different things in addition to substance issues is they were neglected or abused as kids and have complicated relationships with attachments and have self-esteem issues, and then they go into adolescence and have trouble regulating their emotions. They have trouble with impulse control. They have trouble with their self-esteem. They have trouble with eating. They have trouble, just various different things. And for all of us, just thinking back when I was 14 years old, it's like, I would frequently have meltdowns, but feel like I was old enough that I should be able to handle it on my own, and if you were traumatized, your meltdowns are going to be much greater, right? And and if you traumatize, you're typically in a system where you can't really depend on other people. And so you, through trial and error, you discover maybe that, when I drink alcohol or when I smoke a cigarette or when I, use heroin or when I buy this Percocet from my friend and I take it, or I borrow, they give me a Percocet and I take it, suddenly all my problems have washed away.
Yeah.
And I feel better. I'm relaxed. I can function. And okay, and maybe in your teenage years it gets bad, but maybe it doesn't. Maybe it's just like a mild issue. But then that just progresses over time. Meanwhile, you still have frequent fight or freeze reactions to things because you're a human being, and you've never been given a chance to develop functional ways of soothing yourself through grounding or hugging or talking trusting or deep breathing or believing that the world will calm down if you just wait or just don't use your Percocet, just hold on, and it just builds and builds and builds, and substances tend to take its toll. They're cons, right? Everyone wants to sort of maintain their life. Everyone wants to have a good life, but you're at work, you're working at Amazon, and you're popping pills or shooting up heroin during your lunch break or something, and you overdosed slightly and you're too droopy-eyed at the meeting and the boss is looking at you and going like, what's going on? I mean, these are people I treated, and you're like, what do you mean? What do you mean? You're like, and the person's like, oh man, I took too much in the bathroom. Okay, I gotta, and then you cut back and then you're more agitated and irritable and like, you're like, oh God, and it's this constant thing where you're always
torture.
Trying. Yeah. And then you think, well, maybe I should cut back and maybe I should just go cold turkey and like really, and then not only are you dealing with withdrawal symptoms and just all the horrificness of that, but also, and habit withdrawal also, but also again, all that trauma and emotional regulation issue comes back because you haven't been given a chance to develop other coping skills. And then you start pushing people away because people are looking at you like you're a flake, and how come you didn't come to the birthday party? And you didn't because you were worried that you wouldn't be able to shoot up, or you're too ashamed of your shooting up, and so you slowly isolated yourself, and now everyone's just like, well, screw that guy, and like now you're truly alone and you're truly ashamed, and it's like, what's the point of even moving on? I might as well just use heroin. Like that's the only thing I have left, and it just spins out of control.
Absolutely. And that, that's the thing about, it's kind of a both and with other issues and addiction. Now, you could some people will try substances and progress in sort of the manner that you just described. That's one sort of story of progression that you just illustrated. And at some point in that story, right, what happens is it develops a life of its own. And addiction is kind of this dominant, it becomes this sort of dominant set of neural pathways that's really running the show. And so I think competent addiction treatment is understanding what you're dealing with and how loud that condition is so that you're actually prescribing something that's going to contain it.
And CDPs don't necessarily know how to treat trauma, correct?
No, I mean, that's the thing. That's where on the other end of things, they're not, well, it's not in the scope of practice. That's not something that their credential.
It's a complicated thing.
Exactly.
I mean, it's very complicated.
I think.
So the perfect person is someone like you.
Well, for more complicated parts of the journey.
Yeah.
Because in the beginning, the nervous system can't handle a lot. It can't even handle day-to-day roommate interactions in treatment, let alone processing like the deepest pain. So, stabilization, fortunately, much of the stuff that treatment centers do is quite in line with what you would do in phase 1 of trauma treatment.
Yeah.
Regardless if your client had addiction or not, in phase 1 of trauma treatment is stabilization, because most people, if they haven't developed an addiction and they've got pretty complex PTSD, are doing something else. They're cutting, they're suicidal, their relationships are, there's some level of crisis much of the time. So stabilization in sort of the gold standard of trauma treatment is phase 1. You're making sure your client, it's like you can't expect clients to run a marathon. They got to learn how to, do a mile and feel pretty comfortable doing a mile. They're not winded. They're not, 3 miles. They got to learn what they need to resource themselves. When do I need water? When do I need to pull out an orange slide? There's a training of sorts that goes into really doing, more Mount Everest type of work with attachment injuries and trauma. So, that does take a lot of skill, and I have had hundreds of hours of extra training in trauma as well to feel competent in dealing with that. But I would say that many treatment centers are becoming way more trauma informed now, and really even soliciting guidance from some of the leaders in the trauma field to be on their boards and to help them make programs that don't do anything to aggravate the nervous system unwittingly, and that they incorporate more types of things into stabilization treatment of addiction that are conducive to stabilization treatment of trauma. And both of them go hand in hand really, quite well. In fact, another aspect of that is one of the books that is the assigned reading for one of the classes in the concentration is a book that was written by her last name is Merrick, and I'm just blanking on her first name. But she wrote a book that explains 12 steps and adaptations you can do for clients with trauma. And it's things like that are important to know, because that's where the integration comes in. That's where we're able to pull everything that's already been working really well and just do it in a really conscious way and factor in the other stuff we've learned about mental health issues and trauma and attachment injuries.
Cool. So a lot of novice therapists will have, I would say universally, this thought gets into their head, and I was curious what you thought of it, is they will say, well, my client who came to me, at first they wanted to talk about their relationships, or they were struggling with depression or something. Mm-hmm. But I just realized that they're drinking every day at night. Mm-hmm. And so I can't treat them. I have to refer them out. I have to, ethically speaking, I have to cut off treatment from them. And they'll say, isn't that true, Kirk? What would you say to that?
Well, it's one of the goals of the survey class. So the intro class that all our LMHC students and many of the CFT students take is not that they're going to be competent in treating addiction, but I want them to know what to do if it comes into their office and to feel confident in the way that they handle it. Now, I'll tell you, as somebody who was in private practice, most of the clients that I would have where I would stumble upon, oh, wow, you're using a lot. Like, let's explore this. And we spend some time exploring it. How's it impacting? Come to find out it's impacting life quite a bit. My work usually transitions into getting them into treatment. I don't really treat addiction individually. You know, there's so much that has to go into, I know, that life transforming, that it really becomes more about what's stopping you from doing what you really need to do here. But
would you like say, you got to get out of my office?
No.
Like I can't talk to you anymore.
No, of course not. No, I would do a lot of psychoeducation, and I have. I mean, many of the clients I've seen that I've stumbled upon, and I think they're stumbling upon as well. Wow, you're looking at, you have active addiction. You're in active addiction. It'll just transition into me helping them come to terms with that. And then being in reality of what they actually need to do if they want to make a change. And so a lot of times, you know, I sort of partner coordinate with treatment centers where they'll go to treatment for a while and then they'll come back. And I'll be very sort of aware of what they're doing while they're in different phases of their treatment. But no, I'm just very candid with them about what I feel competently I can, like, what I can help them with and what I can't. We study the Gabor Mate a lot. We look at a lot of his talks, and his book In the Realm of Hungry Ghosts is one of our texts in the survey class. And he's made something along these lines. I'm not quoting directly, but something, he says things in the camp of, you know, addiction is the opposite of connection. And I think there is a lot of truth to that. And so what I've noticed is if you look at most treatment centers, whether it's outpatient or inpatient, you'll notice it's done in groups. There's a lot of, because people become very isolated in addiction, even if they're around people. They have a very distorted sense of what's going on with themselves and other people. And so in my experience, that is paramount in recovery. Connection, getting peer feedback, starting to tune into people again. And it's not just something you can wake up and do. I mean, group is a lot of practice. 12-step world, that's a lot of practice, like a little microcosm. They give each other feedback, a lot of it. You know, hey, you're really off the beam. What's going on with you? In a way that family can't. The family relationships are so loaded at that point, and there's so much mistrust, and there's so much breakdown of just basic health, in, you know, and family members need their own help and support. So to get back, you know, to get back to a place where they're feeling better about life and feeling so.
Well, there's a formal nature to treatment groups that develops a culture around being honest, and it allows for tough questions to be asked that in normal society are almost never asked, right?
And it's sort of sad. I mean, when I'm just reflecting on how we are as a society now, I mean, it's, you know, we are kind of missing that a bit of that, just that more community sense or more connection, more.
Totally. Well, it's stigma. Partially. I mean, I have a friend who's actually really suffering from addiction, ongoing, and I've just been thinking about, like, what kind of questions would I ask him if we were both in a treatment group together as participants, or I was the therapist or whatever. And I'm just like, there would be so many things I'd be saying to him and so many questions I'd be asking. Whereas in regular society, because we have so much stigma around it, it's taboo to bring up. And even though I know better, I still don't bring it up with him. I don't ask him about it, because it feels so strange because he's not bringing it up with me, and I'm guessing it wouldn't go well, you know. But if we were in treatment together, and we were both participants, I just turn to him and I would just ask him.
That's right. Exactly. Yeah. There's so much shame. It's just, there's so much shame and so much self-hate when, you know, just the little sort of story you told about a client, you know, I mean, you can see how the shrinking away, shrinking away, pulling away.
Yeah, that's the one thing that I think I learned kind of the hard way in my personal life over the years, which was that the effectiveness at which people can pull away and how insidious and pervasive it is. They basically just become a ghost and they're like invisible and because I would see it as a therapist, mainly how I would see it as a therapist, I would have an adult or a kid who would be complaining about their mother or father who would make promises and not be there, or who would not show up to graduation or not show up to the recital, even though they said they were going to be there. And then I would talk to the person struggling with substance and they would say, "Wow, I really wanted to go, but my car broke down, or there's always some excuse," and it would always be believable, like they're very good at coming up. They develop a very effective way of smoke and mirrors to the point where people who were married to them were surprised that they were using the whole time,
oh, absolutely.
They're just like, so you've been using crack cocaine for the past
it's unbelievable.
5 years.
It's unbelievable.
And it's like, how did I not know that? It's because, people, in order to hold on to that, they become very good at
absolutely
being able to make it so that isn't threatened, right?
Yeah, and have it, and almost start doing it with themselves as well.
Right.
And I think that's what people don't realize is like it isn't a conscious wake up in the morning, I'm going to destroy everyone's life, and my own, like I'm making this decision. It's this sort of slow boil.
It's slippery slope kind of thing. It's like, well, just, I just need to take the edge off today. And, my wife, she gets all up in arms because, she's uptight about that. And, I just won't bother
her. And look
her.
at all the stuff she does. She spends so much money, or she does this. I mean, there's this constant rationalization.
It's my little special time for me. And just a little bit.
I work hard.
It'll take the edge off, and everything will be fine. And then, 5 hours later, you're still not going home because you're too worried about being too high or something. And you're just like, well, okay, and there's just all this rationalization because, as you were saying, the nervous system needs it.
Yeah.
And when the nervous system needs something, like it'll
forget about it. It's on the survival list now. It's like, what am I going to, and then the fear around and the pain and the physical pain. See, so some substances, people actually start to fear being in withdrawal more than anything else.
Right.
It's like that state is so uncomfortable and they become more dysfunctional not using.
Right. Well, that's why there's, methadone and all that kind of stuff.
And then you're just locked in. And that's where it's just torture because these, they can't get out. It's like, so in some ways it's interesting because I've done a lot of assessments over my career. And if I had a nickel for every person that cursed me out after I told them, I think you need to go to inpatient treatment, like, that's the only thing I think is going to help contain things at this point. How many times I've been told, F you, I can't believe, and just parents yelling at me, the person yelling at me. And then 5 months, 6 months later, coming back, you saved my life.
Right.
Because they can't get out of it.
Right.
They need really somebody to pull them out.
And their reactivity is because you're threatening.
Absolutely. It's like saying you can't eat anymore. I mean, it's on that level, in their body. It's terrifying.
Yeah. Or even something even far short of that will cause people to get really angry, which I've experienced in my personal life before too. Just like, this goes way back, but I had a really close friend who just smoked pot like all day long, like woke up in the morning and it didn't bother me. I didn't care. It wasn't a thing to me. But I remember I said something like, I think I said something like, could you just not have the smoke like in my car or like in my room, or could you just like not have the,
like with the same energy as, could you stop leaving your towel on the floor?
Right.
Like it's like a thing that
just like keep it, just, go for it. But like, keep it out of my lungs, you
Yeah.
know, sort of thing, because I'm just walking around in my house.
Right.
And it's this flip switch to
Yeah,
him,
I
and
know.
he targeted me. It was like at the end of it all, I felt like an abused husband or something. It was
You would, yeah.
I was like, how did this conversation get to attacks on my character?
Isn't that, I know.
You know,
I know.
and like I feel so destroyed right now, and like what just happened? You know, because it was. I didn't expect a fight. I expect him to just be like, "Oh, okay,
Yeah,
cool. I'll pick up my towel, no biggie."
Yeah,
or you know what? I don't want to pick up my towel, and and go away. You know, just some kind of. But it was such a threat to him that he decided he was gonna make sure that this never came up again.
Yeah,
you know what I mean?
absolutely.
And he just went for it.
Yeah, and you're describing, the day-to-day life of a family member, and their nervous systems get completely out of whack as well, and their sense of a relationship and what's trust and what's safe and then if you're growing up around addiction, can you imagine developmentally as a child, as you're sort of forming your self narrative, and you're getting these like hostility about like really arbitrary sort of strange things and really dysregulated volatile emotional states, and why is dad hugging me so much and then he's yelling at me the next minute, and it's very difficult to form any kind of like solid internal what's what.
Yeah.
So you can see why there's a lot of attachment injury and why there's a lot of trauma in these families. And Claudia Black said that the rules of a family where there's addiction is don't talk, don't trust, don't feel.
Yeah.
So there's a lot of unwinding, and keep in mind many clients with addiction grew up around it. So there's the compound fracture there,
right?
Which again is why I sought more education and continued to do it, because eventually when people are stable, the lion's share of clients I had in my private practice were people that had been in recovery for several years. And it's really interesting thing that happens. In fact, I really would love to write on this at some point in time, middle-aged recovery, because it's people's lives come back and they start having kids and they start getting careers and they start pursuing dreams. And what I think happens is it taxes their nervous system in a way that sort of is beyond the coping they've learned in AA or 12-step or anything from treatment. It's like it will start to kick hornet's nest of unresolved stuff. So I would have lots of people come into my practice and go, Lisa, I don't get it. Like, I'm doing what I'm supposed to be doing in my program. I'm working with other people, going to meetings, like all these good things are happening. Why am I feeling like I want to use, or why am I thinking about it again? Or I'm having all kinds of weird stuff happen in my relationships. And I said, I think your unresolved stuff's coming and knocking. Like it's sensing your nervous system stable enough to kind of take it on now. And I think, for people who grew up around addiction and then they become a parent, it starts to trigger them in a way that it's kind of oh my gosh, I don't know if I have the capacity to do, they don't have anything to pull from. There's nothing there as a frame of reference, So it starts to really kind of max them out emotionally and psychologically. And so, I would walk a lot of people through kind of building those capacities out and kind of simultaneously having to really face, the stuff that's been haunting them probably all their life.
As a therapist, when this happened to me just last night, I was with some friends and they with their friends who I didn't know. And one of them, I think, asked me what I did or something. And I said, and then there were some jokes like, "Oh, are you analyzing me?" and that kind of stuff.
Yeah.
And so therapists, it's a common reaction to us. To chemical dependency people in our society, I'm guessing you either get a similar or worse kind of reactivity. It's like, oh, like, what? Like, are you judging me because I drink a glass of wine? Like, what do you think about that stuff?
Yeah, that's funny you say that, because I always wonder, like, being even the instructor, the person like in professional settings or whatever that teaches addiction, like even that association, I wonder how self-conscious people become of like, oh, is she looking at me, like assessing me right now or whatever. Right. I think it's hard. That's a hard part about being a therapist and a teacher and a specialist on certain things for sure, and like being around peers and
because
interactions.
A lot of people drink, and pot's legal in Washington now, and so people might imagine if they were on, say, ADHD medication legally, they might think that there's some judgment there or something about that. Yeah. Like, so what do you say to them? Do you say anything like, yeah, I am judging you, or what do you say?
It's interesting, because the reality is it's really only like 1 in 10 people that has addiction. And there's even a fair amount of the population that would really not meet criteria for addiction, that could have some problematic use at some point in their life. I mean, it's another thing we look at again in the survey class. It's like being able to discern or even have some sense of how to organize your thinking around what's addiction and what's problematic use and what's just normal recreational use, because there is a fair amount of that. I mean, there's and many nervous systems have absolutely no abnormal reaction to it. It doesn't impact people's lives. It's fun, it's just something they do at a party or on vacation or even to unwind at the end of the night, but it's really not impacting their life. There's not psychological stress over it. It's enhancing life. It's giving something. It's not taking something away. I think when it starts taking something away and creating more stress, then it's like, it's not really relieving. It's problematic. When it starts to dominate people's lives and completely erode the fabric of who they are and everything that they hold dear, we're looking at addiction.
So to make it a little concrete, because I'm guessing some of the listeners might be thinking about this, is, where is the line? Of course, there is no firm line, but and you're mentioning in terms of harm or affecting your life in a bad way, which is, the general guideline that people follow, but that's kind of a squishy area. So it's like, so you have someone who has 1 glass of wine at dinner, obviously, and nothing bad happens for that because they have a typical reaction to 1 glass of wine.
Yep. No biggie.
No biggie. Someone who drinks enough once a month and has a mild hangover the next day. Are we heading into problem use at this point?
I mean, not even necessarily. It's not necessarily. And it's interesting because there really isn't unanimity in the field around this. Like, I mean, in the DSM-4, we had 2 different categories. We had chemical dependency and we had chemical abuse. So we actually had an abuse category, which I sort of liked because it was different criteria, and it sort of gave some description to what was going on, but it was also a way to describe it in a way that it wasn't saying you're addicted,
right?
But it was like, this is a problem, you're having conflict about it. A lot of times those clients for me are people that are going through something, and what will happen is they'll get into therapy and we'll start dealing with the something, and they find less and less need for it because they're dealing with the something. Whatever that might be. I mean, sometimes it's a life change, sometimes it's a partner left, or, there's something that's going on and they're coming in and they're like, I don't know what I'm doing, or what, God, I'm drinking a lot, and there's conflict around it. And, once we start working through, so, now in the DSM-5, we have substance use disorder, mild, moderate, severe. So depending on how many criteria you're hitting and for how long, in your history.
Correct me if I'm wrong, but to qualify for mild, you only need like 2.
There's like 2 or 3 of the list. Yeah. Now I think
it's a very low threshold.
Right. They need to be happening for a year. Yeah. So there needs to be some time lapse where it's not like I had this 6 months where I was just, I lost my job and I would, it's got to be going on for some time.
Yeah.
But yeah, there's a little bit more room to, it's hard because I do really think there are some people that I wouldn't say are addicted. But they're having a problem with it for sure.
Yeah.
And that's a hard thing to discern. I mean, sometimes you get it wrong. That is just the reality.
Yeah.
You know, sometimes you err on the side of, well, let's err on the side of it is and put you in treatment and see what happens kind of thing, because better to err on the side of safety.
Yeah.
But you can have conversations with clients around that. Like,
Right.
You're on the line. So
Yeah.
what do you want to do? I mean, this is what I'm suggesting. What do you think? And you can have.
Right. Yeah. That's what I do. People often will, before they really have the wisdom of people who actually work in the field will have, or someone who's been through addiction themselves, I suppose, the notion often is like, there's use that is totally okay.
Yeah.
And then there's use where it's totally not okay.
Yeah.
You know, there's this line you cross and you become a, street bum, and you're homeless, and you know, everything is horrible. And the real reality is that it's a spectrum. It's almost like a philosophy to some extent. It depends on how you want to live your life. It depends on, your choices. Cause as a therapist, we could offer opinions, right? We could be like, well, I don't know. It kind of sounds to me like if you cut back, I would imagine your life would get better in these ways.
Yeah.
But it's just suggestion. And if the client says, well, you're probably right, but I like this life. I like drinking 4 nights a week and getting, pretty drunk every night. And yeah, it is hurting my liver. And yeah, it is giving me hangovers. And yeah, it is making it, it's harming my brain, and it's harming my health, and it's
Right.
Occasionally causing me problems with like shopping online at midnight or something.
Which many people do. I mean, I don't know a ton of people that go to treatment. I mean, they exist, but more often than not, there's some external pressure. The manageability gets to the point where they are being intervened on by work, or their spouse is ready to leave, or they do have the third DUI. I mean, addiction is a really powerful condition,
Right.
and people, that is one of the hallmarks of addiction, is use despite negative consequences.
And it just gets worse over time.
It's just like that's not impacting them.
Yeah.
I mean, the what they're getting out of it, or how it's dominating their life and their nervous system far outweighs. That's far more powerful than any of the pain associated with consequences.
Right. My point is that it's up to the individual to decide, and as helpers, we're on the outside providing opinion and trying to help, and trying to offering our own viewpoint, and perhaps paving or laying out a path that is achievable with work, that at the end there's going to be pain. No pain, no gain.
Absolutely. And better that you level with your client. I
Yeah.
usually tell them there's absolutely nothing you're going to really like about treatment.
Yeah,
Like, it's not fun. It's
Yes. And sobriety is boring
but
at times.
worth it. Yeah, but worth it. If you wanna...
In the end, right. But at the same time, there's no morality board that decrees you have a problem, and it's it's a conversation, and it's an evaluation, and there's opinions. And, I think about Christopher Hitchens. Do you know Christopher Hitchens?
I do.
And he drank. I don't know if you know. He notoriously.
I don't know much about his personal story. No.
He was notorious for drinking all the time, every day, and I can't remember the exact. I don't know him that well, but I think he was talking about how in order for him to write, which he was a wonderful writer and thinker, he had to be drinking. And then he ended up dying kind of young. Like,
that's right.
55 or
okay, yes, this is actually coming back to me.
And I think it was related, complications related to his alcohol use. And again, I could be getting this wrong, but from my memory, I think he was saying he was cool with that. He's like, I'd rather die young and have an interesting life, buzzed, and that's my choice, than try to not drink and add on another 20 years to my life. I'd rather go this way,
Yeah.
then, and, I just remember thinking, okay, well, he's a smart guy and he's probably thought about it. And there's probably some denial in there on some level and some lack of hope for anything better, but he made a choice, and that's his choice to make. If he's willing to live with the consequences and he's seeing it with open eyes, then, I can respect that.
Yeah, it is. I think it's just in general an interesting thing to talk about in our field, or just as clinicians. There is this element of philosophy,
what is
my quality of life is
right.
not your quality of life.
Right.
And, even I think that even happens with clients. I mean, I've had to struggle with that and grow with that and get a lot of feedback on that and think about it a lot with clients of because I work with a lot of traumatized people with traumatized nervous systems, and sometimes they get to the point where it's this is good enough. I never thought I would get to a place where I could go to sleep at night without the TV or the radio. Thank you for all the work we've done. I'm good. And I'm thinking in my mind,
there's so much more.
There's so much more. But that's where that is good enough. And, the rest of the monsters in the closet, I can just leave there and I want to move on. I have other clients that are super passionate about, I'm going to seek the truth about myself until the day I die. I mean, and they will be probably in some form of either therapy or self-discovery or learning or, journey for the... So it's an interesting thing. And same with, with people that have addiction, that might be... It's one of the reasons I really like Gabor Mate is he kind of says sometimes the unpopular thing, and
like what?
Well, there's some things that he brings up that are he has, I think, a very compassionate view of humanity in general. And I think when there's a lot of compassion just coming from an elder, there's a lot of acceptance for and nonviolence. It's just this is the human race, and some of us are really struggling, and in a lot of pain. And
rather than having a
standard or some sort of
hard, you need to stop
exactly
using you piece of shit.
Yeah.
You know what I mean? That there's enough of that going on
exactly
internally and in society that as clinicians we don't need to add to that.
And it doesn't necessarily mean also for me, I'm always asking myself as a clinician, I also want to watch that I'm not colluding with a part of my client that's just dominant, and then no other part of them is getting any airtime, because I think that happens in people as well, where it's I am going to go toe to toe with this part of you today, because I think it's just dominating the system, and there is other parts that are kind of trying to get a voice. I don't know if I like this life, and I kind of do want more, and I don't know if I kind of do want to try to be closer to people, and for me, especially clients with addiction, I feel like part of my role or responsibility is to listen deeply enough to make sure that entire person is getting heard and acknowledged. And it's certainly easier not to go toe to toe with the part that's really sort of full front hostile, guarding the addiction, because it's hard work. It's taxing.
Yeah.
But I think if you have good teachers and you watch people that are good at group process with people that are struggling with addiction too, because I had a lot of good teachers and a lot of good supervisors, you start to see that in some ways that system's begging for you to do that, because they can't do it for themselves in that moment, in time in their life. They need somebody to go toe to toe and say, challenge, and I think it's an interesting thing because, the addiction treatment field sometimes gets characterized this is definitely the style of some people as this hard confrontational, you need to get sober or else. I think that's a style of some counselors, but there is such a thing as therapeutic confrontation, where, counselors can skillfully, lovingly, compassionately challenge those addiction neural pathways.
Yeah.
Because, they aren't, I don't know be careful. Don't assume that's the entire person speaking.
Well, and as you're saying lovingly, it's, and I feel like throughout my life, I've basically been mostly conflict avoidant, which is why I'm not a CDP, I suppose.
Yeah. I mean, look, that's a good point. Seriously, because you especially to do group.
Yeah. And so it's been a long journey for me as a therapist to learn how to confront and when and how, and in what way, and what's the vibe that I have as I do it. And I feel like just recently, I feel like I had another step forward because I've started to directly confront students, actually.
Oh, yeah.
This doesn't have anything to do with addiction, but
kind of though. I mean, it can.
In a sense, yeah. But and I think I pulled it off from evidence that I thought, oh, you just really confronted that student. I wonder if she's going to hate me now.
Right.
and from the looks of it, she doesn't hate me. And so, and I did it, and I, in the middle of class, in a way that in the past, I never would have done it.
Right.
I would have just been like, that's a little too much right now. And, or I don't know how to pull it off. But I think the key is what you're saying is, in a loving manner.
Yeah.
There's a way that you can quote unquote confront someone or just be honest in a loving way. It's a vibe that you give across, and it's the intent that
absolutely
that you have. You're not trying to humiliate someone
and you're not protecting yourself, because I think that's when it can get, like, when you get in a power struggle, or you're like, you do have an agenda or an idea and they're not just doing it, and so then you get into an argument, and then it's like this confrontation that's like kind of an argument. I think it's more of, I hear what you're bringing to the table right now, but I'm not buying it, and I'm not buying it in a way because, or with sort of what's in my heart, because I want to, make sure that the whole of you is getting listened to right now.
Right.
And, that's why I really liked learning about internal family systems, Dick Schwartz's work, because it's parts, and it's so much more. It's such great, compassionate language, and it's so much easier to get clients to start to look in at themselves, and makes therapeutic confrontation so much easier by just saying, there's a part of you really coming at me right now, and I just want to take a minute, check in with yourself. Is there any other part of you that has like a different view of what's going on right now? Or is there anything else inside that needs some airtime right now, or any other part? It's like, it encourages them to be the mindful observer with you, so that, it's not all on you.
Yeah.
And super helpful.
Yeah. Well, thanks, Lisa. I think we could talk forever, but let's put a pin in this one.
Thanks for having me.
Yeah. So if you're interested in not only getting a master's degree in counseling or therapy or art therapy, drama therapy, and you want to also become a CDP, then you can come to Lisa Rudduck at Antioch University Seattle and get all your needs met. If you're a licensed clinician post-grad and you want to become a CDP, you can also come to Antioch, and they're working that. Have you had any post-grad people?
We've had some requests, and so I've kind of just started a little bit of a list. I mean, we're really hoping to have the certificate program, which is a way for...
Would it be separate from the concentration?
It won't. It'll be like a blended thing, and once I think that's details we're still kind of having to fine-tune based on kind of numbers and logistics, but... I think what's happening now is the people that have come forward and are interested, I'm just sort of putting on a list and keeping informed. We're hoping to have the certificate program by the summer or the fall. Okay. So that's a little bit of a process, but certainly reach out.
Cool. And you can become, eventually through supervised experience, able and competent and qualified to treat people with their substance use issues, in addition to all the other competencies and capabilities that you have as a therapist or counselor, which is, really something that society needs, apparently. And I guess bottom line, you could also make a fair amount of money because more clients can come to you, and you have more employment opportunities. 'Cause,
Absolutely.
and there's
absolutely more marketable.
Right. So I think that's another benefit to it as well. And it's really not that much extra work.
It's really not. I mean, in the grand scheme of things, you know, to be duly credentialed. And I mean, especially if you think that's something that you're going to want to work with clients with addiction or their family members, or be able to work in different settings. Yeah.
And when you go to dinner parties, you can stand up and point fingers with beer in one hand and your pointing finger in the other hand. You can be like, "You all got problems. Right. I don't have a problem." All right. Well, that does it for that episode of Psychology in Seattle. Thanks for joining me, Lisa.
Thank you, Kirk. Thanks for having me.
Thanks, everyone out there, for joining us. And please take care of yourself because you deserve it. You really, really do.